So today's topic, total system approach. What does that mean? When I show you the chart, you will think, oh, but that's what everybody does and that's what everything that we do. True, but I'm going to dive a little bit to highlight. So for those who feel when I show you the diagram next, that this is something we already do, very good, then now I'm going to show you a little bit more of the emphasis of the something that you already do every day in a little bit more detail and very quickly, right? So we created, we didn't create this, IHI created the system because we felt that adverse events are still happening and it's still a big problem to our healthcare system. So these are some evidence telling you that adverse event is still going to cost you a lot of money and is still a big problem in your healthcare community. So before I go into that, so you can see in the high-income nation, and I won't even say the low-income nation, I'm talking about high-income nation, it is estimated 1 in every 10 patients. This is a published report by WHO. 1 in every 10 high-income nation. We're not even talking about developing nation or middle-income or low-income nation. We're talking about high-income nation. It costs the world each year, 134 million cases, it costs the world US dollars 42 billion annually to manage adverse event and preventable harm. It costs the world 42 billion. And you're talking about, and this is mainly for occur in the hospital. So you can see for lower and middle income countries, you're talking about reported only. These are only the reported ones that WHO can find, not the unreported one. 134 million reports. And these are only the ones that are reported. There are many that are not, and we all know about that. Unsafe medication practice and medication error still leads the cause. And I remember I was in Dubai the year before for a patient safety conference. And people asked me the same question. We have new technologies. We have been doing medication administration for decades. All doctors are trained and nurses are trained to work on administration of medication. We've been prescribing medicine for decades. How did that still go wrong? Very interesting question. So, and I said that the report don't lie. The facts do not cheat. It tells still there is an issue. It warrants us. It is telling us that we need to take a deeper look. It's very easy to say that I'm very good in providing or prescribing and administering my medicine for my patient. I hardly would make mistakes. But still, the facts cannot lie. So the facts tells us now that we have to be looking at that. I'm sorry, I just want to highlight this as well. In all the data that we have seen, and especially from this report, more than half or more than half of the adverse event reported is preventable, i.e., 21 billion US dollars can be saved globally if you want to equate it as such. A lot of money and resources can be saved because more than 50% of it is preventable, and we can prevent those things from happening itself. Now, in the US, we had PSO. I showed you about that, and that is why I want to highlight about PSO earlier. And we've been doing a lot of litigation effort. Medical legal in US is very established. We have patient safety organization, and we thought we are learning from the incident itself, which is good. But David Bates in the US recently did a study, and it is officially published in the New England Journal. You can find them from the New England Journal. In conclusion of what he has researched and published on, actually the adverse event cases and incident didn't go down much. We still have the same kind of incident from 2000 and the early 2000 when we talk about PSO or patient safety. Remember, the patient safety movement was started because of a book, To Err is Human, by Atul Gawande, right? So the movement started because of the book or the published book, publication that was done. So from then, we created so many things, including patient safety learning programs and everything. We have made some improvements, but we still have a lot more adverse events. One of those glaring one is still this, drug events, medication error. So these are still very prevalent in today's adverse event reports. So it tells us that we have done a lot. It has moved the needle a little bit, but not enough, because we're still seeing a lot more things that is still happening today. These reports open up many of our eyes, especially in the world where we research on what we should do in the future for patient safety. And we thought we are already doing enough today, and we are fantastic already. Hey, the report is telling otherwise. It is actually not enough. We still have a lot that we need to do. And these are facts. We're sharing this not because we're trying to make everybody feel that whatever we're doing is not good enough or terrible, but the facts say so. That it requires us to think more and do more, because what we're doing is good, but we need to be better. That's what it is calling for. So IHI, for those who know IHI, if you don't, I won't dive into explaining them, but you can Google and you can look for them. IHI has did a bit more study, and they went around and looked at what are really the root causes, what are really the issues from the national level and global level as to why we haven't been able to do better in terms of reducing those adverse events. A couple of things come to play, right? And this is the concept that was published by IHI not long ago, a couple of years ago, I think. Yeah, so we went in and thought about it. And before they come up with this concept, I will share with you a little bit about their thinking process behind some of the factors that they were thinking about. One of the reasons why cases has not gone down was because we kept introducing new things and new approach into our system, into our care regime. Sometimes, for example, I would use maybe new drug, maybe new technology. I will use this as an example. It's not exactly, but this is one of the examples. Like new technology, when you introduce new technology into your care regime, whether it's for diagnostic or for treatment or for monitoring, you're introducing a new thing. It solves some old problems that we have, but it also brings in some new problems. My question always to the healthcare colleagues is that, do you know what are the new problems? Have you been able to deal with the new problems? Therefore, we take a look at everything else, and then what about human? Has the human been able to deal with the new problems that we bring in? Yes, it solves some old problem, but it also brings in some new, right? Just like your EV car today, it solves the carbon thing in the city, but you also build the carbon somewhere else because somebody still need to burn some coal and give you electricity to charge your EV. Right? Still, we are burning coals. It's just parking the problem somewhere else. But do we know? Do we want to talk about? So in healthcare, it's the same. We bring in many new things into our treatment and our care regime. The issue is that, have we also take a look at what are the dark spots of that new thing that we brought into healthcare? And that is important. So they thought about everything, and they feel that one of the key things that we have to focus on is to create a model that is comprehensive enough. The model looks very simple on the screen right now, and I'll share a little bit more. For safety to happen, for any of our work to be successful or move forward, we need to make sure that we have a culture and leadership. And yes, you are already talking about culture and leadership. I think through the last 2 days, every speaker or every presentation that you go through, it's about culture and leadership, mindset change. That is why Dr. Piyawan was talking about the mindset on day one. It is very important that you need to make sure we have a good mindset to drive a good culture, having leadership support from national level to province level, down to your individual hospital level, very important. If we do not have this, anything you try to do is limited by this is my scope of work, especially if you guys are from the quality and risk team. This is where I can do, this is the maximum I can do only. And that is not 100% solution, because if you're not able to go out of that boundary to solve the safety problem, you are going to leave the problem hanging and you're going to have more issues. So culture, leadership, policy governance are very, very important, and you really need to have this support and have these resources to deal with it. The other one to think about is workforce safety. Yesterday, we had a session here in this room, and we talk about personnel safety. And far too long, for us who work in the hospital, I used to work in the hospital, but now I don't. But for the colleagues who works in the hospital now, far too long we have been ignored, and far too long we have been the ones supporting, but we haven't got the support. And I can tell you, sometimes they try. Sometimes they give incentives, sometimes they give more money, sometimes they do this, they do that. But it is still causing the problem. We are just trying to say that, oh, I know it's difficult, maybe I give you a little bit more extra allowance, maybe you take extra allowance to do the more difficult work and unsafe or risky work. So this is what I have to say to people. Why don't we change how it is done so that it doesn't have to be so risky and so challenging, and at the same time you don't have to pay any extra allowance or something like that. So the root cause of workforce safety is not about we don't have enough money to pay our staff, we don't treat our staff well. No, it is about how we create the work. Our work become very laborious, very tiring, and is very difficult for a human being. Therefore, we need to think about how we can better support that process to make it even better, reducing any chance of those challenging environment for the staff. So that's workforce safety to think about. And that is what total system asks us to think. We have to think from a total system, not just, okay, we can't change the process, let's pay the staff a little bit more money and more allowance. Hopefully that the staff happy and they will do that, no complaint, and they will do it better, and then there is no adverse event. Yeah, that sounds like not total system. Sounds like you're just suppressing the problem and it can come back again. So we want to talk about workforce safety, and that's what total system is asking you to think. People always tell me, but Eric, we always talk about workforce safety. Yesterday we have a session, training people, sharing with people, continuous reminding our staff on what is right to do and what is wrong to do. I agree, all that is fantastic. But the reason why we kept doing something that they keep repeating and there's continuous error from the human side require us to take a deep look as to why is it that it's always causing the human to make the error. Is every human that bad or not good enough? Is our staff, from staff, this year's staff, next year's staff, or last year's staff, everybody would have a chance to make that error? Why is it that it is always human making that error? Did we actually think? So think about that system from the total approach of things, not only just specifically that, okay, human make error, this person forget that, this person forget this. Why is it that it's always that kind of same thematic error? There must be a reason if you analyze this data that you have, and it is why we need more data, and we need more better report so that we can do more analysis, right? The other area is learning system. Learning system today in Thailand, for example, is fantastic. You have a beautiful NRLS system, fantastic healthcare accreditation institute staffs who's doing a lot of work trying to compile this data so that they can share with you. They are working on doing a lot of those analyses so that they can tell you that yeah, there is a same situation or same kind of issue always happening.